Here we are for our second lecture. I'm here with Rose. We're going to be talking about the conventional ventilator that we use in the NICU called the Draeger. Although the Draeger looks very complicated, it's actually pretty simple. We're going to be talking about the different modes that we use. Rose is going to be telling you what each of these numbers mean. We're going to be talking about the graphics that you usually see that we have set up for you, for each patient, and then we're going to be talking about some troubleshooting. So, this ventilator works basically, or the way that we use it, is in basically two modes. Remember that all we are trying to do is to move the baby's chest, to put air into the chest so that oxygenation and CO2 removal can happen at the alveoli. So, for both of the modes that we use pressure or we use volume in order to breathe for the baby, to expand the chest. So, for both modes, we set the PEEP. Remember, the PEEP is the pressure that's there at the end of expiration, and it's there to keep the lungs expanded. So what we have to do is we tell the Draeger either to fill the baby's lungs based on pressure. The peak inspiratory pressure would be the pressure that the ventilator puts in for each breath. So if I say that the peak inspiratory pressure should be 20 and the PEEP should be 5, that's what the ventilator will do. Constant pressure will be kept at 5 centimeters of water, and each breath will go up to a peak inspiratory pressure of 20. We used the Draeger like this for years. The problem is, with each breath, the pressure is exactly the same, no matter what the compliance of the lung. Meaning, in the beginning, the lung can be very stiff and difficult to move. As the surfactant kicks in, or as the baby gets a little older, the compliance gets easier, and the chest is easier and easier to inflate. The goal, what we are trying to do, is put in a volume of about 5 mLs to 5 to 6 mLs per kilogram. If the baby only weighs a kilo, we are shooting for about 5 to 6 mLs. Remember, the tidal volume is the amount of volume that is required to expand the chest. If the compliance changes, for each breath, the PIP is exactly the same, 20, but the tidal volume can change. The tidal volume in the beginning could be our goal, 5 to 6 mLs. As the compliance changes, as we hit those pressures each time, the tidal volume may go up. 6 mLs, 8 mLs, 10 mLs per kilo, and that is overexpansion of the lung. So that can cause barotrauma. So we have gotten away from using pressure, and we're going to talk about now inflating the lung using volume. Instead of telling the machine to insert to a certain pressure, we're telling the machine to insert a certain volume, 5 to 6 mLs per kilogram. That means if the baby wants to take a bigger breath, it can, but the machine is going to guarantee that there's around 5 to 6 mLs per kilo. That way, as the compliance changes, the pressure in the beginning might be quite high. If the baby just comes out of the delivery room and has just gotten surfactant, the amount of pressure that's required to give those 5 to 6 mLs per kilo might be high, 20, 23, 25. As the compliance changes and it gets easier and easier to inflate the lungs, you will see that the pressure, the peak inspiratory pressure, will drop. It'll maybe be 23 in the beginning, half an hour later it might be 18, an hour later it might be 15, so that we are reducing the amount of barotrauma that we're causing the baby. So Rose is now going to talk to you about all the numbers that you see on the screen.
So currently your baby is on pressure control ventilation, and here is your oxygen, here's your PIP, your PIP. This is your mean airway pressure, so whenever the doctor asks you what your mean airway pressure is, you're going to look at this number. This number is your rate. Your minute ventilation, the doctors will rarely ask about. The big numbers that you really want to look at are your volume, which you see are staying steady right now, and your percent leak.
The mean airway pressure, can we use that to decide whether or not the baby's ready for extubation?
Yes, we can. You should watch, and it should be going down, and when it gets down to 10 or less, that's a good sign that the baby is ready to be extubated.
So you told me that this was a respiratory rate, and I see that the respiratory rate is set down here at 50. Can this number be higher?
Yes, anytime the baby assists, the number will go up higher, and you'll actually see it on your graphs. You'll see gray settings, and you'll see a little lung flash up there every time the baby takes a breath.
So can this number ever be less than the number that's set here?
No.
All right, so the minimum rate that this baby can breathe is 50.
Correct.
So if the baby's sleeping or sedated, the baby will get 50 breaths.
Right.
If he's crying or agitated, this can be 90 breaths.
Yes.
Okay.
There's water in the circuit. It can look high too.
So this height of line is about 12. So we would think that this baby should be around 2.5 kilos.
Right.
So once again, we're looking at this number as the tidal volume, 5 to 6 mLs per kilo.
Correct.
Okay, so we're going to talk about graphics, but first let's look at this lower line here. This is the line that is set by the respiratory therapist based on what the doc or the NNP wants for the baby. So this is the amount of oxygen, FiO2. The tidal volume, we want it between 5 to 6 cc's per kilo. Remember we talked about the I time in our first lecture? We set that here. The respiratory rate, the PEEP, we'd like it to be between 4 and 6, can be higher. We don't really deal with the slope, don't even worry about that. And this is the P max, the pressure max. When you're doing volume, you want to tell the machine, I want to know if this baby is requiring huge pressures. So if the baby should be hitting pressures around 18 or 20, I might set this P max, this pressure maximum point, to about 25 or 20, maybe even 23. That way, if it keeps alarming, if it's telling you it needs more pressure to fill up the lung with that amount of volume, I want to know about it, and it's going to alarm and tell you. So here are the graphics that Rose is going to talk to you about. We have 2 bar graphs here, and then we have some loops that we're going to talk about.
The top graph is showing your pressure. The bottom line is your PEEP. The higher line is where your PIP is going. So for each breath, when they exhale, you'll see your PEEP. When they inhale, you'll see your PIP. The next is your flow graphics. And it shows the flow going into the baby. The pause, this is your inspiratory, this is your expiratory, that's your pause in between.
So I have a question, Rose. So what if the distance between this inspiratory part and this expiratory part is too wide? What is that telling us?
Then you're giving your baby an inspiratory hold, and they cannot breathe out as long as it's set at that.
So we have to shorten our I time?
Yes.
All right. So also, if this is the pressure and I'm going by volume, will that pressure change when the compliance of the baby changes?
Yes, it will change.
Okay, good. So it says flow here, and this says volume and pressure over here. So does this flow graphic, is that just what I'm seeing here on this bar?
Yes, you're just seeing it in a different form.
So what am I looking for? Am I looking for this nice round circle?
These are pretty close to exactly what you want to see.
All right. So let's look at, so this is basically the machine is showing you that flow is going into the lung, and the flow then is coming out of the lung for expiration.
Correct.
All right. So over here, this is an interesting graphic. It's a nice round circle measuring the pressure change as it goes up, showing you the volume going up as well. So I wanted to look at this a little closer on my easel, because we all know I love the easel. I'll show you basically 3 graphs of the most common graphs that you're going to see on these volume pressure graphs. So remember that the graph on your ventilator, this is pressure over here, and this is volume. So if I'm using volume guarantee, let's say it's a 1 kilo baby, I set the volume for about 5. So the peak amount of volume is going to be about right here. Let's say this is 5 mLs. So I start down here at I don't know what volume, close to 0. And as the pressure increases, I don't see much change in the lung. Then I reach a certain point and that volume really goes up, like this. And then as the lung relaxes, because the lung is elastic, it has good compliance, the volume stays up, even as the pressure drops, until it reaches a point and then it comes back down. Start over. So this is a very nice pressure volume graph. Pressure goes up, opens up the lung, we reach the end of our inspiratory phase, nice elastic lung, comes back down. And these will look like this. You can even stack them. There's a way to do that on the back. We won't go into that. So you can see that these loops are very consistent for a nice, healthy, compliant lung. We don't tend to have those. So what we might have is a baby with a very stiff lung. So this is a baby who is right out of the delivery room, who just got their surfactant, and their lungs are very stiff. So once again, we have our pressure down here and our volume here. So what we're going to see is that the pressure goes up, 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 but the volume doesn't go up hardly at all. And then comes back down pretty straight, because the lung is not very compliant. Now what we also see as we give surfactant is that compliance starts to change, and those lungs get to be more and more compliant, and they start looking like what we want to see over here. So when you have a lung that's very stiff, this is going to be a very closed, flat loop. When you have a nice open lung and you're using the proper amount of pressure and volume, they're going to be nice and open. There is a condition that happens, especially when you're using pressure controlled ventilation, pressure down here, volume here, is that you get what's called a bird beak. Looks just like a bird. So what is going on is that the pressure is going up, 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 volume goes up. It reaches a point, the pressure continues to rise, but there's no increase in volume. And then we have expiratory comes back down. So this area right here, this bird beak, is telling you that you're using too much pressure. You're causing barotrauma because you're giving more pressure with no increase in volume. So if you start seeing these loops that are nice and round, we've given surfactant, all of a sudden they start getting this bird beak. You can tell us, hey, I think you're overextending the baby. You got a bird beak. And then we'll be able to adjust our ventilator. So that's just kind of a way to troubleshoot what's going on with your baby based on the graphics. So let's do some troubleshooting with the ventilator.
If you see this on your screen, this is when you need to call your respiratory therapist to come and check your flow sensor.
So Rose and I were talking that this is a $24,000 piece of equipment. It is very complex. It uses a lot of graphics, and it is very good at ventilating a small patient. However, it is totally dependent on a $200 piece of equipment called the flow sensor, right up here. Everyone knows what the flow sensor is for, and the ventilator is totally dependent on whether that flow sensor is clean and whether it's been calibrated. So Rose, what are some of the things that'll tell you that you need to calibrate the flow sensor?
Yeah, there's various different things that will come up on the top of your screen. One is flow sensor soiled, one is flow sensor disabled. It may say flow sensor not working correctly. It may say flow sensor deactivated.
So you'll get an error message up here. What's the first thing the nurse should do?
Call respiratory.
How often do these flow sensors have to be calibrated?
When we first start the machine, it requires that we calibrate it before it's used on the baby. Then Draeger wants us to calibrate it every 24 hours. Our policy at Holy Cross is every 12 hours. So each shift should be taking it off the baby and calibrating it. If you see them do it, they actually have to take it out of the circuit and calibrate it off the baby and then put it back in. We also tend to get a lot of water rain out in our circuits, and that will also mess up the flow sensor. And when you take the baby off for something and you see water and shake it out, it might also ask us to calibrate it. So anytime there's any kind of flow sensor message, you need to call respiratory. The most serious ones, you'll see a red line across the screen here. The minor ones, you'll see a yellow line. But you should call us for major and minor ones. Excellent.
So I have a question about respiratory rate. So this respiratory rate is set at 50, and it's set at 50 down here. So the baby is breathing right as we want it to. Let's say the baby is sedated or sleeping, and the respiratory rate goes up to 100. What happened? Why is that? What is one of the causes of that?
The biggest cause is water in the circuit, and you will see the inspiratory circuit dancing around with water in it. or the trigger may be too sensitive.
So why would water in the circuit cause the baby to appear to be breathing fast?
To make this ventilator so that it is sensitive enough for the tiny babies that we have, it will notice everything, and when water is sloshing around, it's just like a baby trying to take a breath.
So the flow sensor is telling the machine that the baby needs a breath, but actually it's just the water bouncing in the tube.
Correct.
All right, and what if the baby's just taking small breaths? Will it pick it up on that? Will the flow sensor pick that up?
It should. As we get tinier and tinier babies, it may not.
What about if you see this happen, so that there's no flow here at all? What could that mean? And I have no graphics here.
So that could mean that your baby is extubated. It could mean that your tube is occluded and you should see obstructed across here, and it happens a lot of times when your tube goes down and touches the cornea. Or it could mean that you have secretions and you need to suction.
So by looking at this machine, either my flow or my graphics over here, my nice circles, I can tell what's going on with my baby.
Yes, definitely.
We talked about rain out. So rain out is bad. It collects in the tube, it jiggles the tube, and the machine thinks that the baby's trying to take a breath.
Correct.
So is there any way to prevent rain out in the tube?
Most of the rain out is caused by having your upper temperature probe turned the wrong direction. I'm just going to move this over here.
Hold the baby.
Thank you. Your temp probe should be pointed like this in your bed. If it lands up turned like this, the water sits on it, it makes it cold. So it's going to keep heating up to try and warm it up. The more it heats up, the more humidity you're going to get, and it's going to end up going to your baby.
And then the machine thinks the baby's breathing fast, and the baby gets 100 breaths a minute when he only needs 50.
Correct.
Okay.
So whenever you reposition your baby in the bed, when you're done, you should turn this so that it is pointing down.
Rose, I've been called at the bedside before when we thought the baby was extubated. But the baby, when I bagged, was clearly intubated, but the machine thought the baby was extubated. Why would that be?
There are a couple places on the ventilator that has fallen apart on us in the past. One of the places is the expiratory tubing. If this slides off, it will create a leak in the circuit, and you'll see a red light. Once it's back on and it's fixed, the light goes away. The other place that comes apart is here where your second temperature probe goes into the circuit. If this falls out, the nurses frequently put the cap back on, and they don't put this back in. The cap will solve the problem with the hole, but that will also create more rain out.
Okay, so we have to make sure this is in place, make sure this is connected, and our problem should go away if the baby's in.
Correct. Anytime there's a continuous red light that doesn't stop, there is either something wrong with the baby's extubated or there's something wrong with the vent. You should not just keep hitting silence. You should call for help.
Perfect. Okay, so that's a couple ideas on troubleshooting the ventilator. We talked about the graphics, but the real way to understand a ventilator is to have a baby who's on the Draeger. When the baby's on the ventilator, ask the MD, the respiratory therapist, or the NNP to talk to you about what each of these numbers mean, what the graphics mean, what happens when you disconnect the baby. You can see all of it, and it makes much more sense to you when you have a baby on the Draeger. So if you have any questions, please write them down, and Rose and I will be answering questions in lecture 5.